So our next speaker is Dr. Carl Black. He's going to talk to us for the next hour. And his topic is on thrombolic iliofemoral DVT. That's mine, though. Okay.
Thank you for the opportunity. Mike, thanks for inviting me. So I'm going to give a couple talks. Hopefully you won't be too bored with me after kind of a tall order, but hopefully I can make this interesting and at least shed some light on why these topics are important. So I want to talk about acute iliofemoral DVT, and I'll just say at the outset that as we think about DVT in the lower extremities, iliofemoral DVT is a unique animal. And if there's anything I want you to take from this lecture, it would be this, that that particular subset in the right patients with low comorbidity, relatively active people with a long life ahead of them, they need to be treated differently than others. Hi, Gordy. And my disclosures. So I want to go over the pathophysiology of what makes iliofemoral DVT unique. We'll talk about diagnosis, what goes into the differential diagnosis, some of the underlying risk factors for this, what predisposes a patient to get iliofemoral DVT. We'll talk about the endovascular options, and then hopefully we'll have a construct for an algorithm that you could take with you into your practice that would allow you to carry this forward and manage these patients perhaps differently than you are right now. So as an interventional radiologist, basically I'm a plumber and I like everything to be open and I like to see flow through things. It looks good, it makes me feel satisfied. But one of the criticisms I think for our specialty is that often there's relatively little evidence for what we do. And although between these two pictures, you have one here on your left that is completely thrombosed. This is an iliac thrombosis, and then same patient after treatment, completely open. And so you have to ask, well, which is better? I think, God created us so that our iliac veins are open, and I would just say the conclusion would have to be that the open vein is better. However, the data's not necessarily conclusive on that, and it depends on where that clot is, which we'll get into. I think the real question is, why do we want to treat DVT? There are probably a couple reasons. One is to prevent propagation, to prevent PE, which can obviously be fatal, and you can have tragic outcomes, particularly from iliofemoral DVT. And can we prevent post-thrombotic syndrome? And that's another thing about iliofemoral DVT we're going to go into. And with the advent of low molecular weight heparin and now the DOACs, the oral anticoagulants, it's become very easy to treat DVT as an outpatient. It used to be a big deal. You'd be admitted. I think people gave it more consideration. What happens down the road is 5 years down the road, often you'll see a patient like this that has an ulcer near their medial malleolus, and they had an iliofemoral DVT about 5 years ago. And they were appropriately anticoagulated. There's no problem with PE, but yet they're left with this. In fact, if you look at all leg ulcers, you might think that diabetes is a big cause or whatever. It's actually venous disease is the most common cause of a leg ulcer. Over 70% of all leg ulcers are caused by DVT. And it's interesting when you see these patients, we see a lot of them because we treat not only the acute DVT, but we'll treat patients who have had remote DVT and open those veins too. And I'm going to show you a few examples of that. That this gets misdiagnosed. Patients are often put on antibiotics. They'll have different topical agents. In reality, this is a plumbing issue. And if you can resolve this early, you can prevent the advanced stasis. Basically, this becomes either from reflux or from obstruction or sometimes both because DVT can damage the valves and lead to venous incompetence, or it can just frankly cause an outlet obstruction centrally and lead to stasis. There's a CEAP classification that ranks the severity, and iliofemoral DVT has a higher association with the clinical severity score of C4, 5, and 6, where you get actual discoloration of the skin, you'll get lipodermatosclerosis, which is scarring in the subcutaneous tissues. It becomes leathery. That skin is very prone to any injury because it's relatively ischemic. So even minor trauma can lead to an ulcer. And then people who are C5 or C6, basically that's a lifetime sentence of either hovering between an active ulcer or an ulcer that's healed. So this is that same patient that I showed you earlier, a 22-year-old female. She presented with a left iliofemoral DVT by ultrasound. Now, on ultrasound, I'll just point this out also, you're not going to see into the iliac veins necessarily unless you really look for it. But conventionally, the sonographers aren't looking that high. So what do you see? Typically, you'll see thrombus at the common femoral vein, or you'll see a monophasic waveform that would suggest there's a central obstruction. This young woman had progressive left lower extremity edema. She had been started on anticoagulation. It did turn out that she had a family history of DVT, and herself, she was factor V deficient, and she'd recently started oral contraceptives. So you think of Virchow's triad, and I'm going to show you a little more anatomical reason why she got this, but she was, there was a perfect storm for her. And so we took the complete thrombosis of her iliofemoral vein. Do you want to play the video? To a patent vein. And this takes 90 minutes. So if somebody has popliteal venous inflow, in other words, that it hasn't propagated down to their calf, you can take someone like this with relatively low TPA. This was only 10 milligrams of TPA, and you have to stent the underlying lesion, but we can take this to a patent vein in a relatively short period of time. Virchow was an amazing guy. He obviously is famous for the Virchow triad, but he also recognized that the incidence of DVT, particularly in women, was higher on the left side. He didn't fully explain what that was. A lot of people have looked into this since, and there's a syndrome called May-Thurner, which was after two pathologists, May and Thurner, who described the compression of the left common iliac vein by the right common iliac artery. And it's not only that, it can also occur with the external iliac artery. Anywhere there's an artery-vein interface, the artery is always going to win because of the pressure differential, and that can create chronic trauma, webbing, and underlying thrombosis. And so in angiology in 1957, they presented their data looking at cadaveric specimens, and they found these webs in the common iliac vein, and they attributed that to the chronic pulsation of the iliac artery on the iliac vein. However, there is a differential, and I'm going to explain a little bit more about this later, but you don't want to just always attribute that to that, because once in a while you'll get fooled. Somebody might have a tumor, they might have a big osteophyte from their vertebral body. So there is a differential of why somebody might have an iliac vein obstruction. Here's what we know about iliofemoral DVT, and this is well established in the literature, that despite anticoagulation, there's a relatively lower incidence of recanalization. Less than 50% of these patients are actually going to recanalize their iliac vein. And it has a much higher incidence, again, about somewhere between 30 and 50% of these patients will develop PTS at some point in their life. Maybe it's 5 to 10 years. But it's what we also know from large case series, registries, and more recently the ATTRACT trial, is that it's the most amenable to thrombolysis. Here's what we know about anticoagulation. Anticoagulation is effective for preventing clot propagation. It's effective for preventing PE. However, it doesn't decrease your risk of PTS, and it doesn't recanalize. It's not a thrombolytic. What we've seen in our specialty, and why this talk is important, is we've seen a technical evolution of how this is managed, going from systemic thrombolysis, which is a little bit, I'll just tell you a little bit about my next talk on PE, that we have in many cases given massive amounts of TPA. I showed you in that first case, I used 10 milligrams of TPA in that young woman. Used to be that people would get like 90 milligrams of TPA. And in some situations for PE, that's the case, and in some cases now for stroke. But I'll show you that the amount of TPA that it takes to actually open a vein is much lower than that. With the advent of catheter-directed thrombolysis, we can go in and target the clot and embed TPA in it. And actually, we found that we're probably overdosing TPA by orders of magnitude of what it actually requires. And then more recently, with the advent of pharmacomechanical thrombolysis, where you're mixing some type of mechanical agitation along with TPA, we can clear the clot fairly readily. So to me, it boils down to three factors. What's changed is lowered the cost, because if we don't have to, we can do this as an outpatient. We don't have to admit people to the ICU for several days and drip them, because the incidence of complication when you're dripping TPA goes up with time and dose. decreased complications when you're using 10 milligrams. The half-life of TPA is about 15 minutes. It can clear relatively fast, although once it's adhered and starts doing its thing, it keeps chewing away at clot for quite some time, and we've improved outcomes. One of the game changers has been pharmacomechanical thrombolysis. And I'm not here to advocate any particular device, but one of the devices we use quite readily is a rheolytic device that basically uses, it's called angiojet, which basically emulsifies clot at the tip of the catheter. And you can use it to embed TPA throughout the target zone and then go after about 30 minutes after that's had a chance to cook a little bit to go down and aspirate the DVT out. And what this has done for us is give us single session potential. It's, if somebody has popliteal venous inflow, their popliteal vein is open, it's rare case that's now where we drip the patient overnight. It's usually single session, we have them open. This is a 33-year-old female, left lower extremity edema. She had the left iliofemoral DVT picture on duplex, and she was 3 weeks post C-section. So in the old days, we would worry because, oh my word, she's recent surgery. If we drip her with TPA, what's going to happen? Are we going to cause a bleeding complication? Well, with her, we can now just go in with a pharmacomechanical device using around 10 milligram of TPA. And the, let's see, does this have a pointer? Oh, yeah. So you can see here's my guide wire. And my guide wire, if you remember that picture where the iliac artery comes down, my guide wire loops here. I'm able to get it up, but it loops here, and that's because I can't get it up into the IVC. It's because that iliac artery is pushing on the iliac vein, and she also probably has one of those webs that May and Thurner described in angiology. So this is an angiojet going through, and we lace it with TPA. And then we have to stent the underlying lesion to tent it open against the pressure of that artery. But after that, it was wide open. And again, that's a single session. And then we anticoagulate her according to chest guidelines. And that, I'll just emphasize again, just because we do this, we still anticoagulate everybody according to conventional chest guidelines. Nothing changes. Other technologies include direct aspiration, some devices that can actually move the clot completely out of it. The best practice guidelines from the American Venous Forum suggest that we need to understand fully why someone got a DVT. And over the course of my practice, I've had to learn and relearn a lesson that if you assume that it's just maybe May Thurner or it's a conventional DVT, you're going to get fooled once in a while. And so there's an imaging menu that you want to look at. The tools we have are ultrasound, which is our gold standard for looking at the periphery, but it's not very good for centrally because that's for overlying bowel gas, body habitus, other things that can get in the way of looking at a vein. You can also look at CT and CT angiography. That's excellent for the anatomic detail, and your ability to do 3D reconstruction is outstanding on that. MR we can also use. No radiation, however, MR is very susceptible to any motion if the patient breathes, if there's bowel gas. So I find CT better than that, and then obviously catheter-directed venography. Although these days, we only use catheter-directed venography with an intent to treat. So what do I need to know if somebody has an iliofemoral DVT? I want to know its most central extent. I want to know if it goes up into the cava. Do they have an old IVC filter I need to worry about? Do they have tumors? Do they have lymphomas? Something pushing on it? This just shows on CT. You can see the phlebitic reaction around an iliac vein. This is a patient who had a filter, and often we'll see these patients. They'll come back, they're hypocoagulable, and if a patient has a filter and they can be anticoagulated, that's generally a good idea because it is a foreign body. But this patient had clot all the way up to the cava. We had to lyse that to get them open. But sometimes you can be surprised. In this patient, we found a mass. This patient has an inguinal hernia. Just incidental findings. So let's look at what the literature says. I think we were all hoping that the ATTRACT trial, which was recently published in the New England Journal, would definitively show that it's better to open the vein than not open the vein. Well, there were some limitations with the ATTRACT trial. It was a randomized trial that was in Canada and the US. It's the largest trial of its kind. It probably won't ever be repeated, but it failed to meet its primary endpoint of preventing PTS in all comers. However, if you look at the subset, if they looked at severity of PTS and the prevalence, and initially the study was designed only to look at iliofemoral DVT. However, they later expanded it because they were having trouble with enrollment, and they started including popliteal and calf vein and other things that were confounding factors. But it failed to meet its primary endpoint for all severity grades. However, for the really severe post-thrombotic syndrome, it showed there's definitely a difference. It also showed in a subset analysis that if you look at pure iliofemoral DVT, those patients lyse well. And so for patients with low comorbidity who have isolated iliofemoral DVT, it's definitely the way to go. So what have we learned since ATTRACT? I think TRACT has reinforced a lot of what we already knew in practice, but it's reinforced a few things. Patient selection is key. Iliofemoral DVT with popliteal patency is a home run, and if somebody has low comorbidity and they have a long life expectancy, you should consider catheter-directed thrombolysis. Single session in these cases, it's very low risk. We also have better imaging tools. Now we can use ultrasound to actually image the inside of the vein. And so during the period of ATTRACT, when it started in 2009 to now to 2015 when it stopped its enrollment, there was an evolution in technology. And that's the problem with some of these trials where you're evaluating specific technologies, is that there's an evolution that catches up. And if you could go back and repeat the trial, it would probably be even more obvious in favor of lysis. We also know that we don't do anything different on long-term anticoagulation. It does appear that Lovenox, instead of a DOAC, has a short-term benefit of being an anti-inflammatory and improving patency. So when we've intervened on somebody, generally we put someone on low molecular weight heparin for a period of 2 weeks at least, and then put them on a DOAC to let things settle down because it's more effective. IVUS is just another tool we use that wasn't typically used in the ATTRACT trial, where we can actually take an ultrasound probe inside of the vein and we can image the dimensions and see webs. So this is, I was on a committee with Intermountain Healthcare looking at VTE, and this is the algorithm that we settled on that we decided was multidisciplinary, that if you look at someone with major symptoms and a low bleeding risk, and a patient prefers aggressive therapy, it should be part of an informed consent that you could consider catheter-directed thrombolysis. And I think that's about right. This was another case. This was a 20-minute case I did. 37-year-old, he had just come off of an overnight flight from Japan, really severe leg swelling, and he had DVT there. You can see thrombus in his femoral vein. Popliteal vein was again open. I just went through, and in 20 minutes and 10 milligrams of TPA, we had him open, and then he just went on to continue his course of anticoagulation for 3 months. So let's talk about the severe cases where really it's not equivocal. Sometimes lysing a clot is you're trying to spare the limb, and that's what's happening with phlegmasia. You can see the abnormal limb here where actually you're getting ischemia, and this is limb threat. So there are two types of phlegmasia, the albidolins and the cerulidolins, and basically these, I'm not sure you need to, other than knowing that they can present different ways, these are emergencies that where catheter-directed thrombolysis is definitely indicated, and you shouldn't wait around. You need to get these patients lysed, and they'll turn around quickly. Sometimes you can even get these patients open in a single session or maybe overnight, but they'll turn around quickly if you catch them early. This was a patient who I treated, very nervous about it, who had phlegmasia. I normally would never treat someone who had just undergone lumbar fusion surgery, but this patient developed phlegmasia. And so we went in, it was only with the neurosurgeons pushing us, went in, and with 10 milligrams of TPA, we were able to open that up, and that was open within an hour, and the patient did fine. So this is just, and it'll show you a couple other cases. So this is a thrombus, what we see on venography at the femoral vein. This case, the obstruction was right around the inguinal ligament. So the obstruction's not always at the iliocaval confluence. And there you can see with a balloon a tight stricture, and we just had to lyse through that, and then that eventually required a stent placement to keep that open. The stent patency, by the way, is quite high. The primary patency rates are above 80%, Secondary patency rates are higher than that, and that's why we follow these patients out to a couple of years. So when we treat this, we still implement all the normal best practice stuff. We use compression therapy. We follow them out to 2 years. If somebody seems to have recurrent DVT, they have a family history, you want to consider whether you should do a hypercoagulable workup, and then always decide who's going to manage anticoagulation. That's one of the things when you have a lot of players here that we've been burned on this sometimes, where we think somebody else is going to manage the anticoagulation. So more and more, we're managing the anticoagulation over the first couple of years and just making sure that at least if we don't know who's doing it, we'll do it ourselves with that patient. So lessons learned, we consider getting a CT. I want to know why they got that DVT. The pharmacomechanical thrombolysis has been a game changer. Sometimes we'll use aspiration to suck out clot. Palpatory flow is key, and we follow anticoagulation guidelines. So just to, again, summarize this, just think of it this way. If somebody has clot in their IVC or their iliofemoral vein, if it's unstable, we might put in a temporary IVC filter. That's rare, but if they have a clot that's dangling up in the cava, and with the slightest movement of your catheter, you think that's going to launch a clot to the lung, you can put in a filter and then take it out. Then we will lyse that if they don't have any contraindications. Femoral popliteal, they're really going to be fine with anticoagulation, and that's the arm where the ATTRACT trial showed that there really was no difference in anticoagulation. And popliteal, when it's occluded, unless somebody has phlegmasia, we generally don't go after that. So really quick, I just want to talk about in my few minutes before my next talk, about some chronic things that can happen. If you ever see somebody with varicose veins in their subcutaneous tissues, their abdomen, you have to think something centrally is going on. And basically, there's collateralization around that central occlusion. So this is just another example of how CT in a coronal reconstruction can show you the aorta coming down with the iliac artery pressing on the iliac vein, and then that translates to this. So there are people who will come and see us who have an ulcer on their foot, or they have chronic leg swelling, particularly on the left, and they'll have an occlusion there. They don't have acute DVT. This was also described by other people, but they have these webs. And this was a venogram I did that I just compared it to this article, and it showed the web just like this article, and it showed the web right there, so you need to stent around that. But you can see anatomically that's a risk factor. So what are the indications if somebody doesn't have a DVT, but they have something going on in typically their left leg? Certainly if they're C4, 5, or 6, if they have the symptoms of lipodermatosclerosis, if they have active ulcer, these are patients where referring them to the interventional radiology is a good idea, because we can look centrally and see if that iliac vein is compromised. Because if everything else is okay, you can turn these patients around and significantly improve their life by taking care of that central occlusion. This was a 52-year-old female that I treated who was C6. She was the patient I showed you earlier, and she'd been using compression stockings. This at venography, this is what I found. I found a chronic, everything looked good until I got to her iliac vein. And then I was able to just get through that. Even though it's scarred, you can still get a wire generally through that, and then you can stent that. And so now, what do you do with this patient? Well, we anticoagulated her. I gave her a Lovenox transition because Lovenox it's more effective, it's more reliable in the short term, and then we transitioned her to a DOAC. We do coordinate with wound care, although it's important to know that hyperbaric oxygen does not have a role in healing of venous ulcers. This is a plumbing ulcer. For arterial ulcers, it does. And then we just continue to follow her. She had some additional superficial venous insufficiency, which we addressed also. This just shows that with iliac stenting, you get sustained ulcer healing. The difference in those lines is the different segments of either reflux or obstruction. But the literature shows that if you open these patients up, you'll get sustained ulcer healing. And then I'll just close with this on a few patient selections. So first patient is a 65-year-old male, COPD exacerbation and PE. acute onset right lower extremity edema 5 days ago, and extensive iliofemoral DVT and phlegmasia. So in this case, it's tricky because there are some comorbidities. I would say it'd make me a little bit nervous of what I would do with this patient, but the phlegmasia really sort of limits you of what you need to your options. And I think for limb threat, you really need to go for catheter-directed thrombolysis. Because they have COPD and they've had PE, I think in this case it makes sense to also put in a filter because their ability to accommodate an additional clot to their lungs is going to be pretty low. Next patient was the 22-year-old female that I treated earlier. I did put a filter in her because there was some clot that was going up into the IVC. I've never really seen a situation where we've caused a massive PE that was hemodynamically unstable, but there are patients where I'll put a filter in and then take it out. And then in her case, we did a common iliac stent. 70-year-old healthy female with worsening left lower extremity edema. She had a DVT 4 years ago. In her case, we did pharmacomechanical thrombolysis and then you stent the iliac vein. But often these patients will present with their second or third DVT. We treat them about the same. And then you have a 90-year-old female, iliofemoral DVT, recent flight, subdural hematoma. This is a tough situation because you're not even going to anticoagulate these patients. And in this case, we would just put in a filter. Filters traditionally have been overused in the U.S., especially with the advent of temporary filters. And I'll just a cautionary note about that is just make sure you know why you're putting a filter in, and then every filter needs to be tracked. And we've implemented, and Mike's been part of this, where we make a decision before that filter ever gets placed, we want to know what the disposition of that patient's going to be. Who's going to track the filter? Was it put in for a temporary indication or a long-term indication, to make sure that we follow it and get it out in a timely way if it shouldn't be there. So in summary, just remember that there's unique pathophysiology with iliofemoral DVT. If you recognize it and you treat it, you can save a patient a lot of comorbidity. It's important to understand the extent of DVT and why they got it. And not everything is a May-Thurner, not everything's due to that iliac vein, and sometimes you'll be surprised. We've been surprised with patients with lymphoma or other tumors. Endovascular options have become quite effective. Single session is not unusual at all now. And just remember that venous ulcers in the lower extremity, often if you have a patient like that, we can make them better and turn them around. And I would just encourage you to implement this into your practice algorithm, and I think the evidence is strong enough that you can consider this an evidence-based approach to iliofemoral DVT. Thank you. Any questions? Yeah.
You mentioned chest guidelines for anticoagulation afterwards, but if you place a stent in someone with May-Thurner syndrome, are you doing long-term anticoagulation to prevent clotting around that stent as well, or are you still following chest guidelines?
Yeah, great question. Okay, so if you have a non-thrombotic iliac occlusion, the patency rate on those is close to 100%. And so you don't even, some people will treat those patients for 6 months with an antiplatelet like aspirin or Plavix. If you have a thrombotic occlusion and you placed a stent, basically, if you just follow the chest guidelines, the only thing I'm maybe deviating off of that is there's a period of time when you need to make sure that they're appropriately anticoagulated, and we've been burned several times, and I think people see you put someone on Xarelto or Eliquis, that's not quite as effective in the short term at preventing clot right after an intervention, and so Lovenox window helps with that. But the chest guidelines, if you follow those, that'll keep the stent open. We do follow those patients, though, and if there's evidence of recurrence, we'll go back in and re-angioplasty or look at it. And if you can document stent patency out to 2 years, the odds of that stent going back down are almost zero.
Question, if you have someone with an acute pulmonary embolism, how important is it to find the peripheral clot, or where does it come from? Because sometimes they'll do a peripheral ultrasound and not find any source of that clot.
Management's going to be the same, and so I would say it becomes more of an academic issue. I think standard of care, though, would be to identify it. Certainly, if you had someone who had iliofemoral DVT, that might be someone you would consider lysing. But small peripheral DVTs that are maybe down in the popliteal vein probably are of no clinical consequence in terms of how you're going to manage that patient, because the chest guidelines will be identical. But I do think standard of care is to do a bilateral lower extremity venous duplex at a minimum. Beyond that, if it's a recurrent PE and you don't know why they're getting it, I think you need to consider malignancy, other hypercoagulable states, and do a hypercoagulable workup.
Thank you.
So patient that we inherit, I'm over here.
Oh, sorry.
So we have a patient with chronic leg ulcer that maybe we've inherited, don't really know whether there's been an evaluation in the past. Any particular workup that we should do before we say, let's go see our interventional radiologist?
Well, if you're convinced it's a venous ulcer, and the typical characteristics of arterial ulcers are going to be generally embolic, and that's what you're going to see typically in the diabetic patient. They're going to be at pressure points. You'll often see them in the toes. The typical venous ulcer is going to be up on the medial or the lateral malleoli area, and they're usually going to be associated. If somebody's going to develop an ulcer, usually you're going to have stasis, all that hemosiderin deposition and the lipodermatosclerosis. So in those cases, I would just say, look, it's venous. I would just send them to the interventional radiologist for a workup.
In patients that we see on occasion that have calf pain or swelling, but they're low risk on a Wells DVT score, we'll do a D-dimer test to see if we need to move on to an ultrasound. Sometimes we'll have a patient with an elevated D-dimer, but they'll have a negative ultrasound. In patients like that, should we just assume that they might have a small below-the-knee DVT and treat them symptomatically for that? Or should we look further in those patients and do other studies besides an ultrasound, like a venogram?
So if I understand the question correctly, no objective imaging evidence of DVT or PE.
Correct.
But they have an elevated D-dimer, and there's no other reason for the elevated D-dimer, no recent trauma, no recent surgery.
Correct.
I don't know. I think the consensus in this room is going to be probably better than mine on that, and so I could speculate, but I don't think I'm any smarter on that than you guys. Okay, all right, we'll start the next one. Okay, so let's talk a little bit about PE and where we are with PE. One of the things that we have learned over the years in interventional radiology is that systemic thrombolysis generally does not get to the clot. We've learned that in stroke, that if somebody has a large proximal M1 occlusion in their brain and you give them TPA, it's probably not going to turn them around, and in fact, you may be predisposing them to intracranial hemorrhage. With PE, there is data that shows that you can reverse the right ventricular dysfunction with systemic TPA, but you may not really clear that clot in a timely fashion. And then also we know that, like with DVT, systemic lysis won't touch that. You really have to get to the clot. And so just at the outset, if you remember anything from this lecture, I think catheter-directed therapy in the right patient can quickly lyse a clot, and you can decrease the amount of TPA you give. And by doing that, you decrease the complications. So that's in a nutshell my take-home message with this, and now let's just go through some of the data. So hopefully at the end of this, you'll be able to understand the role of imaging and the way we would assess the severity of PE and stratification depending on the imaging tool. Well, hopefully you'll be able to understand what endovascular options are for PE. And these would overlap with some of the surgical options, which are rarely used. And then obviously we're going to compare that to the systemic options and why those are or not being used currently. And then again, I just want to emphasize that hopefully you can take the data that I present here and integrate it into how you manage PE right now so that you have an evidence-based approach. I hope there's enough equipoise in how I'm presenting this that I'm not just like hammering this that every patient needs to go to catheter-directed thrombolysis, because that's not the case. We know that PE is a major issue. About 69 people in every 100,000 will develop a PE. And elderly, it will go up, and then obviously there are some patients with hypercoagulable states where it's significant, and then you have to worry about subsets of patients who are either post-op. Often you hear those tragedies after total knee or total hip replacement surgery where a patient dies suddenly. And one of the problems with PE management is, and I think we're all susceptible to this, is you tend to manage patients according to your last worst outcome or your last worst emotional experience. Because you think of how emotional that is for someone to die suddenly of a PE, and you think, wow, if I would have only put in a filter. Okay, if we would have only been a little more aggressive on it. And it's really hard to practice medicine that way, and it's hard to overcome that bias, but it's real, and I'll just put that out there with PE as one of those cases. It often originates from the lower extremities, and with iliofemoral DVT, if you look at all comers of PE, 50% of those cases will have clot in the lower extremity, and a significant number of those will have iliofemoral DVT. Fortunately, PE is mild in most cases. It doesn't compromise us hemodynamically, the capacity for the lung to take a little bit of thrombus burden, and then through our own pathways of lysis, it'll clear without any sequela, and those patients just can be anticoagulated. Then you have the other extreme of the high-risk PE, where there's a very high mortality. These are the patients who present to the ER with hemodynamic compromise. Their blood pressure is going to be less than 90 systolic. They're going to have very low oxygen saturation. They're teetering on the edge. Those become medical emergencies. And those also, I think there's relatively little debate about what to do with those patients. Those patients need to have some type of intervention. The CHEST guidelines right now would suggest that those patients need IV therapy right away. However, I think that's nuance now of what we know. And this is just what it looks like on CT angio. CT angio is excellent. You can do three-dimensional reconstruction on it. This would be a classic saddle PE, and the saddle comes from the PE actually overlying the bifurcation coming out of the main pulmonary trunk where you're going into the right and the left pulmonary arteries. And then in this case, you actually have clot burden down both pulmonary arteries. This is where hopefully today's lecture will help us, is when we look at the intermediate risk. Some people call this submassive PE. I think the purists who deal with PE and the experts in VTE don't like the submassive concept. They call it intermediate risk because it's really a risk profile. But these patients have a significant mortality at 3 months, so it's not benign, but often these patients get, I think, maybe triaged to a lower standard of care. And so that's probably the most interesting population for us that we'll focus on. So we're going to focus on this intermediate risk to high intermediate risk. So basically what happens with significant PE is you get right ventricular dysfunction. And that's what leads to long-term your mortality with that. By CT, we have an indirect measure of that. We're not measuring motion by CT, but we can very easily look at the dimensions and compare that to the dimensions of the left ventricle. If the ratio between the right ventricle and left ventricle exceeds 0.9, that patient is at risk for right ventricular dysfunction long-term and carries increased mortality with that. If you couple that with a biomarker, like troponin, and it goes greater than 0.04, then you couple those together, that patient is at high risk of right atrial dysfunction. And so that's a patient that would be at least in the intermediate risk, if not the high-risk category. High-risk category, they self-define because they have hypotension. And I think it's just basically the greater the dilatation of the right ventricle on CT or the greater the troponin, basically the more dysfunction. And this is how we measure it with CT. So on CT, what we'll find is we'll find a dilated pulmonary artery, and you compare that to the aorta, you'll see that once the pulmonary artery should be less than the aorta, and once that ratio reverses, then you have pulmonary hypertension. Then you can also measure, if you look at the level of the valve and you come 1 centimeter off the valve, you can come across the right ventricle and the left ventricle, and what we do is we measure the opacified lumen, and that's how we can give you an RV to LV ratio. And I think most of the radiologists now, Mike, I'm pretty sure we're all using conventional templates when we do a PE study, that if somebody has a PE, one of the metrics in our report is going to report out the RV to LV ratio, and that'll give you an idea. And the number you want to look for is 0.9 or greater. So why lice? It's because there's long-term data that really the chest guidelines were published off of in the pulmonary literature that would suggest that if you decrease the RV afterload, you're going to decrease mortality long-term. And it's also shown, many studies have shown that if you take two cohorts of patients of heparin alone or anticoagulation, systemic anticoagulation versus systemic thrombolysis, the systemic thrombolysis, even though it carries some risk, are going to fare better at 5 years. They'll have decreased mortality. That's where the chest guidelines come for the high-risk PE and intermediate-risk PE of giving systemic thrombolysis. The predictors of early death are basically arterial hypotension. If somebody is hypotensive, they have over a 50% chance that they're not going to leave the hospital. That's why that becomes an emergency for those patients. And if you have obviously imaging or biomarker evidence of that, that will supplement that. But those are surrogates for hypotension. Hypotension is the clinical manifestation because often you can have the elevated RV to LV ratio and an elevated troponin, you may not have hypotension. And that's really a differentiator between the high risk and the intermediate risk. So we've been through that. CT angiography just gives excellent anatomic detail, and also this is so quick. With multi-vector CT now, you can have this information within just a couple minutes off the scanner. Echo still plays a role, but I'd have to leave that to a cardiologist to comment on where echo might fit into this, but CT certainly has a high positive predictive value of showing RV dysfunction. So the chest guideline right now, currently, is that in patients with acute PE who are treated with a thrombolytic agent, we suggest systemic catheter-directed therapy using peripheral vein over catheter-directed thrombolysis. And I think this is an evolution, and this is nuanced, and I'm going to show you because even in the recent chest guidelines, they've qualified this. So if the chest guidelines are that patients with significant RV dysfunction should receive systemic thrombolysis, I'll tell you it's inconsistently administered. And I think I'm biased at Utah Valley. I think Gordy would probably be biased too. We have some of the best ICU doctors. I'm sure you have good ones here too, but I think these guys are amazing. But they'll tell you they really are nervous about giving IV lysis. And it's because you kind of live in that anecdotal world of your last intracranial hemorrhage or a patient who had a bad outcome from that. And so there is, when you give someone 90 milligrams of TPA peripherally, you know that some bad things can happen with that. That's a lot of TPA. So it's not without risk that we do that. And so this is everybody's fear. And so the general literature would show that we are that if you give systemic thrombolysis, you're going to cause an intracranial hemorrhage in about 1.8. This was in the studies done at academic institutions. In real-life clinical practice, it was about 3%. So it's low, but it's not absent. And everybody kind of lives in that 1.8 to 3% world. And then, I can't blame anybody for doing that, but this in part at least accounts for why systemic thrombolysis is not administered, so people aren't necessarily following the chest guidelines, ironically. So there may be other options. This is the chest guideline with this highlighted here, that patients who have a higher risk of bleeding with systemic thrombolytic therapy, and that could be a patient who's maybe recently had surgery, maybe they've, they're older, they have other comorbidities. Those patients, you might want to consider catheter-directed thrombolysis. And then they qualify that if you're at an institution that offers that. Fortunately, in this community, you have those resources here in Ogden, so that's not an issue. So it's interesting with this nuance that it is recognized that probably catheter-directed therapy is going to be a favorable option in these patients who have high risk and in some cases intermediate risk PE. I just want to quickly show you a few trials. Here's the data that would support catheter-directed therapy. The next 3 trials I'm going to show you used a device called ultrasound-assisted thrombolysis. And the idea was that you put an ultrasound probe that's on a catheter into a clot, and it agitates the clot, and loosens up the fibrinogen and exposes the receptor sites for TPA to start working. In Ultima, they found that using TPA over a period of about 10 hours, 1 milligram of TPA for 5 hours, then 0.5 for 10 hours, over that time period, they were able to reverse RV to LV ratio to a normal level. And they found that there was no major bleeding complication. And so it was kind of a breakthrough trial that you're using a fraction of the TPA you would give systemically, and they dripped these patients for up to about 15 hours, and they were able to achieve these results. And this was just what they found, that if they compared it to heparin alone, and they found the RV to LV ratio decreased, and if you look at heparin alone, it stayed about the same. So this part was no surprise because we already knew that from the pulmonology literature, critical care literature, but what was surprising is we could do it with a very low amount of TPA. And you could do it in a short period of time, less than 24 hours, you could have that reversed. And it seemed to be sustained when you followed up to 90 days. The cohort that got lysis had a normal RV, normal RV function in a larger patient population. And this is just what happens is if you expose this, and it exposes the plasminogen receptor sites. The Seattle 2 trial was an extension of that, and here they enrolled more patients. They were giving 24 milligrams of TPA out to 24 hours, and in this trial, they did have some major bleeds, but no intracranial hemorrhage. And major bleed was anything. It could be of anything that might require hospital admission. It could hematoma at the access site, but they had no intracranial hemorrhage. But they did find that the RV to LV ratio was reversed significantly at 48 hours. Then Optilice. The interesting thing about this trial is that we went to a really extreme on TPA. And in this case, we were giving less than 10 milligrams of TPA in very short periods of time. And then they just looked at these patients at 24 hours and then followed them out to 90 days. And in this study, they were looking at giving either 4 or 8 milligrams of TPA, depending on whether it was unilateral or bilateral. And the highest they gave was 12 or 24, but they found that if you gave as little as 4 milligram of TPA into a unilateral clot, and you did that over just a couple of hours, you were getting the same reversal of the RV to LV ratio that you were getting with the prolonged higher doses of TPA, and these were all better data than you were ever getting with systemic IV thrombolysis. So then the question would become, well, why don't we do this with everybody? And there's some bias with this. The weakness of this literature is it only goes out to 90 days. The strength of the pulmonology literature, where the chest guidelines come from, is that went out to 5 years. So you'd have to say, okay, is this a significant surrogate endpoint where you could say, okay, if we reverse the RV to LV ratio at 90 days, does that carry the same significance as what was found with IV thrombolysis at 5 years? And you guys will just have to decide, but that's the crux of the issue. Because if we had 5-year data on this, I don't think we would be debating this. So basically, Ultima, Seattle 2, and Optilice basically showed that low-dose TPA in less than 24 hours, and in the Optilice situation, less than 4 hours can reverse your RV to LV ratio. And not a single intracranial hemorrhage in these bleeds. And more importantly, with Optilice, where it was just a couple hours, they had no bleeds. Not even any, there were no major bleeds at all, even outside the brain. This was just a real-life series done in clinical practice that was published, where this was at a single institution in 45 patients, no readmissions. They had arm hematoma, no intracranial hemorrhages, and they found similar results to Ultima, Optilice, and Seattle 2. So in summary, we can reverse the RV dysfunction with low dose of TPA. And the reason that there's IV TPA is not being given is because of the fear, I think, of the major complications. So really what's changed in the world of PE is I think that now we're seeing an increased safety and efficacy profile with catheter-directed thrombolysis. I don't think it's really a stretch to say that for high-risk PE, someone who's hemodynamically unstable, that they should just go to catheter-directed therapy. Their only other option is a surgical embolectomy, and that is in the chest guidelines, although I've talked to our thoracic surgeons, and there's at least one thoracic surgeon at our hospital who's never even seen one of those. So it's not typically done in an acute PE setting, but catheter-directed therapy is definitely done. You don't have to use the ultrasound-guided probe. You can actually use less expensive options, and this trial looked at that, where they just took a pigtail catheter, and you can take a pigtail catheter up into the pulmonary artery and twist it and kind of agitate the clot and pulse spray in some TPA and get it going, and they were having similar outcomes, actually, with just a simplistic approach as putting a pigtail up into the clot. This is how the catheter looks that's used for ultrasound-assisted thrombolysis, and then this is obviously how pigtail catheters look, and these are bilateral PE. And they just found that between these two modalities, both modalities showed improved RV to LV ratio and RV function, and no statistical difference. Other techniques for removing this are continuous aspiration, where you use no lytic. And I think this has some limitations right now of just how much thrombus you can get. I think coupling this with TPA is promising. This is an example of where somebody has clot, and then you can actually extract it. We do this quite a bit in the legs too. So, and we use this with stroke. It's just that sometimes the volume of clot relative to the size of this catheter can be overwhelming for the catheter. And so these technologies suffer a little bit from high burden PE, but I think that you'll see an evolution of that too. So anyway, so let's just kind of bring this to a close, is that with PE stratification, fortunately, most of your PEs you're going to see are going to be in the minor category, and these patients are going to do fine with chest guidelines of just anticoagulation. Then you have the submassive, which I think probably the more appropriate term is going to be intermediate risk, where you have an RV ratio of greater than 0.9 and a troponin of greater than 0.04. And then you have the major, where you have that plus hemodynamic compromise. And so these are the guidelines that we used, and I was part of this same committee, and we concluded that, and I think this is an appropriate evidence-based. Some of what we have to do is just pragmatic medicine, and when we say evidence-based, I think it's just a group of people coming together, and this includes critical care physicians, where you're going to monitor these patients in high intermediate, and if they start to drop their pressure or vasopressors are required, then you start considering what are probably the non-controversial high-risk options, which are going to be catheter-directed or systemic thrombolysis. So you'll notice you'll give interventional therapy, and then there are two options recommended at our institution. You can give systemic thrombolysis, or you can do catheter-directed. And I will just freely admit I'm heavily biased towards the catheter-directed arm of this, as opposed to systemic thrombolysis in this category. So how would you mobilize this? I think forming an interdisciplinary team. With all of this, the patients are going to fare better if we all collaborate and everybody comes together with their opinions, and you build a consensus of how you want to manage this. And if you don't already have an institutional protocol for this, I would recommend that you do that. A PERT team is basically a PE response team, similar to a trauma team or similar to a stroke team, where basically you make a decision beforehand how you're going to triage patients. And if you wanted to use this algorithm, these slides are available, by the way, on the website, then you basically come up with an algorithm of how you're going to triage and manage PE. You know how everybody's going to respond, and you have a reproducible method. Because if you have something that's reproducible, even though some of it may not be perfect, it'll still evolve with the literature, and at least if you do things the same way, you can tweak it and improve it. But it takes the variability out of it. So I hope this helped, and I hope that gives you at least a glimpse into the systemic versus catheter-directed options for PE and why we might choose to intervene, whether it's with systemic therapy or catheter-directed therapy. Thank you.
So question on, so if a patient is admitted to the hospital for a PE, for example, would you say that you should get a lower extremity ultrasound 100% of the time? Or if not 100% of the time, what would be the reasons for getting an ultrasound and what you would learn from that would change your management?
Well, yeah, these is a great question. So I think it's always good to know where clot came from if you can identify it. And so because the incidence of PE significant from upper extremities is really low, but if they had iliofemoral DVT, for example, that might change how you would want to manage that DVT simultaneously with their PE. So that would be one thing you could consider with that. I do think that there's some of it might be checking a box or be just academic, because the reality is, unless you have a DVT that you're going to treat in some catheter-directed fashion, the treatment's going to be identical. So I'm not sure I'm the best person to answer that question, actually. It's a tough question, but I think most people do try to find out where the clot is from, and but if somebody has DVT, or excuse me, confirmed PE by CT and you didn't do it, would that be a breach of standard of care? I wouldn't say it is, because I don't see how it changes management. Next question.
What's the incidence of putting in filters with a pulmonary embolus for you?
Okay, so I think in the that might be, and that's a great question, especially in relationship to why we might get lower extremity ultrasound duplex. If you knew that somebody had an iliofemoral DVT and you could demonstrate significant clot burden by duplex at their common femoral vein, and by CT, you saw that they had an elevated RV to LV ratio. So now you're in the intermediate to high risk category. Their ability to accommodate more thrombus in their pulmonary bed's pretty low. In those patients, putting in a filter is probably a good idea. Certainly if you get up to in that high risk category and somebody has clot burden, and you have duplex evidence of that or other imaging evidence of that, that's a reason to put in a filter. If you look at all comers for PE, just because someone has a PE is not a reason to put in a filter. But if somebody has right ventricular compromise, heavy clot burden by CT, and I would say you can demonstrate the clot burden, that's a patient that would probably benefit from a filter. They don't necessarily, depending on their life expectancy and their comorbidities, it would probably be, we always assume that every filter is going to come out unless we make a decision specifically of why that filter is going to stay in for life.
Second question, what about chronic pulmonary emboli with pulmonary hypertension?
So in those cases, if they have clinically significant pulmonary hypertension, then those patients may benefit from embolectomy with thoracic surgery. Lysis would have no role in that.
Thank you.
TPA has been used for a number of things. Started out with heart attacks and strokes, where TPA was used most prevalently. But initially, TPA had a lot of rules behind it in terms of where you could use it and where you couldn't use it. A lot of contraindications to TPA. Where are we sitting with those contraindications, and maybe specifically, if somebody is on an antiplatelet agent, can he get TPA?
So I would say that antiplatelet agents are relative contraindications. Absolute contraindications are, well, and even absolute may not be absolute. It's really nuanced, because the case I showed you of that patient, the 48-year-old male who had just undergone lumbar fusion, that would be an absolute contraindication to giving TPA in most people's books. But if you're going to lose your leg, I think that was a risk that patient was willing to accept, and you have a neurosurgeon involved who could manage a subsequent epidural hematoma if it occurred. But the difference is the magnitude of the TPA, because in that case we used 10 milligrams of TPA, which has very little systemic effect. And we've treated now a lot of patients who are recent post-op, who have iliofemoral DVT, whether it's C-section, whether it's bowel resection, other surgeries, because it's often easier to manage a bleeding complication than it is to manage the sequela of phlegmasia or bowel ischemia or other things. So I think it always becomes relative, and generally with catheter-directed therapy, if you can keep your TPA duration under 24 hours, and certainly if you can keep your TPA dose under 10 milligrams, I've not seen many complications, even in really precarious cases, from that. I do think it's a game changer when you use an order of magnitude more of TPA than that. When you're in the systemic lysis, I think that those are cases where it's dangerous. Okay, thank you.